record. Perfect. So thank you again for joining us this morning. Could you introduce yourself and the work that you do at UC Irvine?
Sure. I'm Dr. Pranav Patel. I'm an interventional cardiologist and the chief of cardiology at UC Irvine.
Awesome. So what disease conditions do you treat? And specifically with regards to the TAVR, what does that treat?
Okay. Well, interventional cardiologists mainly, certainly in the past, were treating coronary artery disease. So if someone was having an acute myocardial infarction, it was our job to go into those coronary arteries, open those vessels up by performing balloon angioplasty and stenting. As the specialty has progressed, we're doing more and more structural heart interventions. And over the last 6 to 10 years, we're actually replacing heart valves percutaneously using catheters, using really the same techniques that we use in the coronaries, except it's bigger equipment. So this is non-surgical replacement of, in particular, with TAVR, which is transcatheter aortic valve replacement. So this is replacement of the aortic valve in certain individuals.
Very cool. What is important to know about the disease conditions you work with and the treatments for those diseases?
Well, specifically for TAVR or transcatheter aortic valve replacement, we know that it affects a certain population in our community. And we don't really understand why people develop it. They usually develop it either as they're getting older or sometimes in congenital disease when they have a bicuspid rather than a tricuspid aortic valve. But we do know that the disease progresses. Eventually, the aortic valve becomes very stiff or stenotic. When it becomes stiff or stenotic, there's a chance that it will cause a cardiomyopathy or a left ventricular dysfunction. And when that occurs, the chance that the patient will have multiple hospital admissions becomes much greater. This is for symptoms of heart failure. They typically present with symptoms of fatigue and dyspnea exertion, a lot of times attributed to getting older rather than the valve itself. Some people have chest discomfort, and in some cases, some people pass out and have syncopal episodes. But when they start developing this cardiomyopathy or left ventricular dysfunction, the chance that they will die from complications of this disease is pretty high. It's 50% over the next 2 years and 80% over the next 5 years. And so this is mechanical problems. There's no medicines that can treat it. The mortality is high. The quality of life that someone has is very, very poor. And the only way to fix it is valve replacement. So we know from data, if you left these individuals alone, and actually the initial research for TAVR came with really sick individuals with aortic valve stenosis who the surgeons declined to take to the OR for surgical valve replacement because they felt that they would die on the table. The initial trials were performed on these individuals, and half of them received TAVR, the other half were left alone. Those who received TAVR had a better quality of life and lived longer. So we know that if we leave people alone, that's not the right thing to do. And we need to treat them if they are appropriate candidates. So from the very high risk, now we can perform TAVR in low risk individuals. This particular year, it took over surgical valve replacement for the aortic valve as being more commonly performed. And obviously the big difference is, patients are going home in 1 or 2 days with just a couple of sutures in the femoral artery area rather than an open sternotomy. So there's a mortality benefit, a quality of life benefit. There's a reduction in hospitalization, and really sort of all good things for patient care. I think that's why we perform, and that's why it's done so well. Some of the data suggests that you only have to treat 4 to 5 people to save 1 life. And this is, in comparison to some of the heart failure drugs that we use, which are very, very good, but it may take, 20 to 30 patients to be treated with heart failure medicines to save 1 life. So transcatheter aortic valve replacement is a tremendous therapy, and certainly here to stay.
That's wonderful. That's so cool to hear. And I'm glad that the outcomes for the patients are so good and positive and successful. That's great. Have there been any recent improvements with this specific surgical procedure? And if not, do you see any room for improvement?
Well, so there have been improvements in TAVR technology and techniques, and I won't call it a surgical procedure. I'll call it a non-surgical procedure, sort of a transcatheter procedure. The valves have got better. They've been much more easily delivered in the body and the aortic valve region. The equipment has got smaller. The things we worry about are vascular complications. So the initial equipment was using somewhere in the region of 20-22 French, which is probably the diameter of my thumb. And now it can be 14 or 16 French, which may be my little finger. And hopefully we expect the technology to get better and better. The next thing would be, how these valves are working, every time the heart contracts. So, how long will these valves survive in the body without needing to be replaced again? I can tell you that surgical valve replacement, certainly the bioprosthetic valves, which are different from mechanical valves, the bioprosthetic valves last for about 12, maybe 15 years. And when they fail, the patients have to come back and get another valve. And for these patients, we're actually putting in a TAVR. Because it can be very risky to go back, usually in elderly patients, to open up the sternum again. So, that would be, the next thing is, the equipment gets smaller, the valves get better. And then we try and start moving on to the other valves in the heart. The mitral valve, the tricuspid valve. Can you replace those valves in some way? I think the technology is amazing. We see that some of these newer technologies and techniques are out there in the research setting, and hopefully we hope to see them at bedside over the next few years.
Mm-hmm. And for the replacement valve, what material is it made out of?
So it's a bioprosthetic valve. So basically the leaflets of the valve are made from animal tissue, porcine or bovine. It's surrounded by a metal alloy, which is very flexible. It's a lattice of a metal alloy. And then depending on the valve that we use, and there are, at least 2 to 3 valves in this country and more in Europe, there is I suppose a sort of a PTFE sort of graft substrate as part of that valve as well, to make sure that it works appropriately. These are all supposed to be, benign substrates, and should not, produce any sort of inflammatory reaction or long-standing inflammatory reaction in the body.
Okay, good to know. I think those are actually all the questions that we have for you today. So thank you so much. It's been super interesting to hear a bit about what you do and, the wonderful technology that allows you to treat patients and help them, live healthier, happier lives. So thank you again. And